I'm assuming treating these wounds properly is the best route to get from wound to no wound, infection to no infection. How does a patient know if the patient's getting optimal care? And for that matter, how do we measure as a profession? How do we measure optimal care? Is there some metric out there? Notice the profound silence here.
Yeah, that remains a problem in medicine in general. You know, what is the appropriate measurement for value delivery in healthcare? And we're trying to get at that answer, but ultimately it has to come back to what we call patient-reported outcomes, which remain very scarce right now, validated patient-reported outcomes. And then of course the costs associated with those outcomes. So unfortunately right now a patient just can't know for certain the quality of care they're receiving in an easy fashion, the same way that you could go on the internet and figure out what's the best vehicle for you. There's tons of information out there, but there's not on providers and on the delivery of healthcare.
All right, what about us? If a patient can't tell, can we tell? Do we know? Someone comes in and says, I've got this wound and I had this done. Can you sitting here say a priori, that's proper treatment, that's improper treatment? Can you say that?
So there are people like us sitting at this table who, have a better opportunity to make a guesstimate as to whether or not that patient's doing the right thing and getting the right care. But I would say, on average, patients don't know, and frankly, clinicians don't know. They're just not educated because they're marginalizing to a large extent what these wounds can do and what the impact can be.
And that's interesting to me because I started thinking about this knowing I was going to be here today. And it occurred to me that nobody really pays attention to this, or at least almost nobody, the way they probably should. These are huge problems.
The focus is large as physicians and in the community as a whole. The focus is generally on the comorbidity. Why did this person get a wound? But more often than not, the cost driver to a complication regarding the comorbidity is the actual wound.
It's the 800-pound gorilla in the room.
Correct.
Right. We've got this thing.
Exactly. Where we're treating the condition as a chronic condition. The problem is the chronic wound doesn't have the same level of treatment as a chronic condition. There are protocols, there are centers of excellence, but no standardization tools to be able to execute those standard of excellence and those protocols across all venues of care.
Then let's lay it out. For those watching, listening to us today, a chronic wound, improperly addressed, whatever that may be, because you've pointed out how vague that is. The quality meter wiggles a lot. What are you looking at? If you're not treating it right, what are the complications? What do patients get?
So depending on the comorbidity, diabetes certainly would be the most significant. Patients very often develop infections. Those infections seed to bone. Often these patients...
osteomyelitis.
Osteomyelitis. These patients have peripheral arterial disease, both large and small vessels. They often need some type of vascular intervention in order to improve that scenario.
So surgery?
Surgery.
Either with a catheter or otherwise.
That's correct. And unfortunately, patients will succumb to amputations.
Okay.
Now, once those amputations occur, not only is their quality of life significantly altered, but their morbidity certainly and mortality increases exponentially, and many of them are dead within 5 years.
And one thing you didn't mention, I'm sure not intentionally, is sepsis.
Right.
In other words, you get this suppurating infection, whether or not you're going to have increased trouble with diabetes or amputation or osteomyelitis, get bacteremic. And all heck can break loose. I would say all hell breaks loose, but this is television, so we can't do that. We can't. And the sepsis alone will drive you.
Well, sometimes even trying to treat the comorbidity or the problem actually leads to making it more difficult to treat the wound. As Dr. Snyder mentioned, you have a diabetic patient with a diabetic ulceration. There's a lot of difficulty there. They have poor circulation and they have problems with their heart, so they end up having other vascular issues. So what is prescribed for dealing with that complication of diabetes, which is cardiac rehab, adversely affects the patient with a chronic wound on the foot because they can't move, they can't do the exercises in order to be able to do that. So it's a very complicated problem, sort of a lot of chefs in the room and a lot of cooking that needs to be done in order to properly treat that wound.
I wanted to get back to the marginalization issue.
Sure.
Because there have been some studies done that showed that neuropathic ulcers in patients with diabetes have a higher mortality rate in 5 years than cancers, particularly prostate and breast cancer and Hodgkin's disease. So if you think in terms of the fact that a generalist clearly would not treat cancer in his office, that patient would be referred to an oncologist. The same does not hold true of a chronic wound. That patient presents to a family practice physician who will treat that patient, not really understanding what the potential ramifications are.
That prism is really interesting because it's true for a lot of different chronic conditions. If you tell somebody you've got heart failure and your ejection fraction is, pick a number, 20%, that person leaves the office going, I got heart disease, I can live with this. Doesn't realize the morbidity in 5 years, mortality in 5 years is higher than lots of cancer. If you said you've got cancer, they leave the office with a different mindset altogether. And these wounds fall into that latter category of really bad, really morbid, and lethal. How do we change the perspective for providers so they understand what's going on?
I think as wound care professionals, we have an obligation to really educate the generalist. So I think education is multi-pronged. First and foremost, the patient, the doctor who's treating or the healthcare professional who is treating that patient, the caregiver, and also the generalist, because the generalist really often is the gatekeeper. If you're thinking in terms of dollars, that gatekeeper very often will hold on to that patient for a significant period of time. The wound will not heal, and then the patient winds up in the emergency room with necrotizing fasciitis and sepsis, as you pointed out.
This is a difficult problem.